Good afternoon, everyone. I'll be presenting a work on next generation collagen imaging using PSOCT to understand keratoconus and post-CXL outcomes in thin corneas. So, cross-linking has been established as an effective treatment for advanced keratoconus in thick corneas. When it comes to thin cornea, we still have issues to come about. Like we need to modify our cross-linking technique to ensure endothelial safety in thin corneas, and the only other option is corneal transplantation, which has its own disadvantages. So, coming to the existing techniques of modified cross-linking we have available to address the challenges in thin corneas. All these techniques have some or the other modification needed during the technique. Some of them require additional solutions. We may have to modify the riboflavin solution. Some require corneal tissue, and some require modification of the UVA light source, etc. So, can we devise a technique which does not require any additional equipment, does not require modification of riboflavin solution, which is simple and can be executed by every ophthalmologist who treats keratoconus? So this is we thought is going to answer this. So NXT UVA calculator is based on customizing the UVA on time to the thinnest corneal thickness of each cornea we treat. So it is based on Lambert-Beer equation, where the incident energy is per centimeter square is still 5.4 joules, but the incident energy gets attenuated at deeper depths of the stroma. So the total irradiation dose is still is made sure that it is still lesser than endothelial damage threshold, which is 0.35 milliwatts per centimeter square. So, I'm showing the center. I'm showing you the equation how we derive the UVA on time, and it is different for both the 0.1% and 0.2% riboflavin solutions, because the absorption coefficients are different for both the solutions concentrations. So we have put across this technique before, but what I'm trying to address in this study is not we should to show the outcomes not just with topography, which only assesses the surface changes, to show you the effectivity of this NXT UVA calculated based technique by looking at the collagen fibril orientation. So PSOCT is a functional extension of OCT, which not only looks at the how the OCT the light behaves with the tissue, it also looks at how polarized light interferes with the corneal tissue. So this is our in-house built PSOCT, which we have built in association with the University of Vienna, which has a capacity of in vivo imaging in the humans. So apart from, it is a spectral domain OCT, apart from being an ultra high resolution OCT, it also gives you the polarization sensitive imaging. It basically gives you the information on the birefringence of the cornea. So, since it is a high resolution OCT, it gives you epithelial thickness, Bowman's thickness, stromal thickness, so segmental layer thickness, as well as collagen orientation. So this is how we study the ENFAS maps of the PSOCT. So the central regular orthogonal arrangement of the fibers gives depolarizes the light completely, and that is what is seen as this homogeneous central purple or blue color of the ENFAS maps. So in in keratoconus, because of the derangement or the irregular arrangement of the collagen lamellae, this regular central blue color is lost. So we wanted to assess the stability of keratoconus in thin corneas post cross-linking using PSOCT. This is our study workflow. So after initial diagnosing and addressing and assessing whether the patient has progressive keratoconus or not, we assess the thinnest corneal thickness and then remove epithelium. After intraoperative pachymetry, we calculate the UV on time and then proceed with accelerated cross-linking. So this is how the interface looks like. You can just input the thinnest corneal thickness and then get out the time duration needed for the cross-linking. So these are the outcomes. So there is significant flattening and also stabilization of the keratoconus in all the treated eyes. Apart from the significant flattening, we also noticed that the collagen fibril orientation is either stable or has improved post cross-linking. So there was no derangement of collagen fibril orientation after cross-linking in this thin cornea cohort using the NXT UV calculator. So, addressing there are two groups which work on customizing UVA on time in thin corneas. But apart from demarcation line and topography, we believe that showing that collagen fibril orientation is stable after cross linking using the NXT UVA calculator is a better effectivity marker than just using a demarcation line and topography outcomes. So we do know that we need modifications of cross-linking to address thin cornea cross-linking. Customization of UVA on time has been shown as a simple way to treat thin corneas, but this is the first study to establish its effectivity apart from topographic outcomes, showing that collagen fibril orientation is stable or improves after cross-linking using the NXT UVA calculator. Thank you.